Very good morning, students. Today we are going to discuss about drugs used in the treatment of angina pectoris and ischemia. So what is this angina? So as per according to definition, angina pectoris is the clinical manifestation of ischemic heart disease, characterized by sudden, severe substernal discomfort or pain which may radiate to the left shoulder along the ulnar border of the left arm. Now, we will have to understand certain things if you would like to understand angina. So, the heart has a smaller blood supply in relation to its oxygen consumption compared to most other organs. When we talk about coronary flow, so coronary flow controlled mainly by physical factors that includes transmural pressure during systole, then vasodilator, metabolites, then coronary blood flow also depends upon the dilatation of the coronary blood vessels, hydrostatic pressure, subendocardial crunch. In the left ventricle wall and other tissue, blood flow during systole and diastole means during both condition blood flows, but in the left ventricle wall blood flow only during diastole. So normal coronary blood flow can increase up to 500%, and this is a special feature of coronary artery. A more important feature of coronary artery is this: it is the functional end arteries, and coronary blood is 30% saturated with oxygen, while blood in the skeletal muscle arteries is about 60 to 70% saturated with oxygen. So, therefore, during high demand, means during exercise or during exertion, coronary blood oxygen requirement is met only by increase in the coronary blood flow, while in the skeletal muscles, oxygen requirement is met by taking depth from store, that is 60 to 70% saturated blood. Now, coronary ischemia is due to atherosclerosis and causes anginal pain. Sudden ischemia is usually due to thrombosis and may cause cardiac infarction. Coronary spasm sometimes causes angina, that is called variant angina. Then cellular calcium overload result from ischemia and may be responsible for cell death and initiation of dysrhythmias or arrhythmias. Overall, myocardial oxygen consumption is mainly determined by the preload, that is venous return and stretching of heart, afterload, that is peripheral arterial resistance and heart rate. So when the oxygen supply to the myocardium is insufficient for its need, it means imbalance between oxygen supply and oxygen need. It ultimately leads to myocardial ischemia. That is being explained in this diagram. You see, there occurs increase in the sympathetic activity, which ultimately leads to increase in the cardiac output, decrease in the cardiac efficiency, which ultimately leads to myocardial ischemia. Because of the myocardial ischemia, there occurs decrease in ATP, decrease in the ionic pump, increase in the intracellular calcium, protease activation, and membrane damage that ultimately leads to necrosis and cell death. Similarly, on the other hand, there occur receptor activation, then ICE-related protease activation, then PARP inactivation and DNA fragmentation that ultimately leads to apoptosis, which ultimately leads to cell death. So these are the two mechanisms of the cell death, and you see certain thrombolytic drugs like aspirin, oxygen and nitrates ultimately inhibit myocardial ischemia. The pain because of the myocardial ischemia may be controlled with opioids. ACE inhibitor ultimately helps in reducing cardiac output and cardiac efficiency. And beta blocker ultimately controls sympathetic overactivity as well as dysarrhythmia. See, pain is due to accumulation of the metabolite in the cardiac muscles. Three forms of angina are there. Number one, classical angina. It is also called as stable angina or angina of effort. The pain is induced by the exercise or exertion or emotion or all of them that ultimately leads to increase in the myocardial oxygen demand. As there is narrowing of the coronary arteries due to atherosclerosis, they cannot dilate to increase the blood supply during exercise. Hence, there is an imbalance between oxygen supply and demand. Second one is the variant or Prince metal angina that occurs at rest, and it is caused by the spasm of the coronary artery. And the third one is the unstable angina. As the name itself suggested, it occurs at rest, but pain is unstable in frequency and duration. And this is, you can say, more worse type of angina, which ultimately deterioratingly progresses to myocardial infarction. So, drugs are used to improve the balance between oxygen supply and demand, either by increasing oxygen supply to the myocardium, means coronary dilatation, or by reducing the oxygen demand, which means reducing preload, afterload, or heart rate, or all of these. So these are the mechanism by which drugs act. Now this is about the classification of anti-anginal drugs. You see, the first one is the nitrates, that includes nitroglycerin, isosorbide dinitrate, isosorbide mononitrate, penta, erythritol, tetranitrate. The second category is the calcium channel blockers, which includes verapamil, diltiazem, amlodipine. And third one are the beta blockers, that includes propranolol, atenolol, etc. Then potassium channel openers, that includes nicorandil and pinacidil. These are the drugs. Some other drugs like antiplatelet drugs, aspirin and dipyridamole. These are another important group of drugs which are very, or you can say, extremely beneficial in the management of angina and myocardial infarction. And certain miscellaneous drugs like trimetazidine. These are the cytoprotective drugs. Now let us discuss one by one. The first one is the nitrates. So let us discuss about the chemistry. The term nitrates is used in this chapter to encompass both nitrites, ester of nitrous acid, and nitrates, that is polyol ester of the nitric acid. Then second one is the glyceryl trinitrate, that is nitroglycerin, and is the prototype of this group. Nitroglycerin and amyl nitrates are the volatile liquid at room temperature. Other nitrates are solids. So, this is about the mechanism of action. You see, endothelial cells releases certain relaxing factors, and nitrates also releases certain chemical, that is ultimately nitric oxide. Now this nitric oxide convert guanylyl cyclase into guanylyl cyclase activated, right? So when this GTP will get merged or activated by guanylyl cyclase, this will get converted into cyclic GMP. Now, dear friends, myocyte light chain kinase, when stimulated by myosin light chain kinase, get converted to myosin light chain phosphate. Now, this myosin light chain phosphate in combination with actin ultimately leads to contraction of the muscle. But cyclic GMP ultimately act on the myosin light chain phosphate and convert it to myosin light chain and releases free energy, which ultimately leads to relaxation of the muscle. This is the mechanism by which this nitrates, or you can say nitric oxide, ultimately leads to relaxation of the coronary vessels. Pharmacokinetics. The nitrates are readily absorbed through the buccal mucosa. The skin, the gastrointestinal tract, and the lungs. The nitrates are broken down in the liver by glutathione-dependent organic nitrate reductase and are excreted as various nitrites and nitrates. Now, the pharmacological effect of the nitrates are effect on the heart. The major effect of the nitrate on the heart is to reduce myocardial oxygen requirement relative to myocardial oxygen delivery. Nitrates are believed to dilate the large epicardial and collateral coronary arteries selectively, an action that favors the distribution of the blood to ischemic areas. They do not increase the total coronary blood flow in the patient with atherosclerosis. The second one is the extracardiac effect. It is vasodilatation of the cerebral vessels produced by the nitrates results in increased intracerebral pressure and sometimes headaches. The nitrates dilate vessel in the skin resulting in flushing. So these are the ADR of this drug, you can say. Route of administration, nitroglycerin is usually given sublingually. However, for long-lasting effect, nitroglycerin may be administered either orally or topically. Nitroglycerin may also be given intravenously in medical emergencies. Septic uses of nitroglycerin. Number one, stable angina. Sublingual nitroglycerin is the drug of choice for acute anginal attacks. It relieves pain in within 5 minutes, you can say. If the pain is not relieved, the dose may be repeated up to 3 tablets in 15 minutes. Even though if it is not controlled, then you can think for myocardial infarction, carry the patient immediately to hospital. Second one is unstable angina. So intravenous glyceryl trinitrates as a supplement to aspirin. Then cardiac failure, nitrates are also useful due to their vasodilator property. Myocardial infarction, IV nitroglycerin is used by many physicians to control myocardial infarction. And in the cyanide poisoning, nitrates convert hemoglobin to methemoglobin, which bind to cyanide, forming syn-methemoglobin. It thus protects the important enzyme from binding to cyanide. Amyl nitrite is preferred. Early treatment is very important. Uses related to relaxation of other smooth muscles, for example, uterine and biliary. These are the two important which are being used for the investigational purposes. Adverse effect, as we discussed previously, headache is the commonly side effect of the nitrites that usually decreases after few days of the treatment. Patients usually develop tolerance to headache. Then dizziness or the weakness and cerebral ischemia associated with postural hypotension occurs occasionally. Nitrite ions, when present in large amount, can oxidize enough hemoglobin to methemoglobin to result in hypoxia. And sometimes death can occur with acute nitrate poisoning from circulatory collapse or respiratory failure. Tolerance. When nitrites are appropriately administered intermittently, tolerance does not occur. The second group of drugs for the management of angina is calcium channel blockers. See, the depolarization of the cardiac and the vascular smooth muscle cells depends on the entry of extracellular calcium into the cell through the calcium channels. This calcium triggers the release of intracellular calcium from the sarcoplasmic reticulum. All this calcium ion causes contraction of the cardiac muscle. Now, calcium channel blockers inhibits entry of calcium by blocking calcium channels. This results in the following action. Number one is smooth muscle relaxation. Number two, action on the heart, means there occur depression in the myocardial contractility and coronary circulation, effect on coronary circulation, increase in the coronary blood flow. So let us discuss about how this calcium channel blocker acts. See, These are the calcium channels. Here, calcium channel blockers act. So in the calcium channels, or through calcium channels, calcium, intracellular calciums enters. It will bind with the calmodulin and forms calcium calmodulin complex. Now, this myosin light chain kinase, you can see the myosin light chain kinase will get activated by this calcium calmodulin complex and get converted into activated myosin light chain kinase. This myosin light chain kinase activated ultimately activates myosin light chain, and because of this myosin light chain phosphate will form which bind with the actin, and ultimately contraction of the muscles takes place. This is the mechanism. Calcium channel blocker ultimately block the entry of the calcium inside the channel, and ultimately this contraction will not occur and there occurs relaxation of the muscles, which leads to dilatation of the coronary blood vessels. So because of this, ultimately there occurs smooth muscle relaxation, that arterial dilatation reducing peripheral vascular resistance leading to a fall in the blood pressure. Reflex tachycardia may occur with some. Calcium channel blocker depresses myocardial contractility, reduces heart rate, cardiac work, and myocardial oxygen consumption. And the third one, coronary circulation. Because of the coronary vasodilation occurs increased coronary blood flow, hence they are useful in variant angina, that is vasospastic type of angina. Now see calcium antagonists. Calcium antagonists block calcium entry by preventing opening of the voltage-gated L-type and recently T-type of calcium channels. Three main L-type antagonists typically you can say that is typified by verapamil, diltiazem, and dihydropyridines, that is nifedipine. The classification: nifedipine, nicardipine, amlodipine are the hydropyridines. Others are felodipine, lecidipines, nimodipines, etc. Second one is the verapamil and diltiazem. Pharmacokinetics. Now, verapamil, diltiazem, nifedipine, and nicardipine are the rapidly and most fully absorbed after oral administration, while amlodipine is slowly absorbed. Peak blood flow: nifedipine 30 minutes, diltiazem 1 hour, verapamil 1 to 2 hours, nicardipine 8 to 9 hours, amlodipine 6 to 12 hours. All five drugs are highly bound by serum proteins. Verapamil undergoes extensive first pass biotransformation in the liver, while all five drugs are excreted as metabolites in the urine. Pharmacological effect of calcium channel blocker: cardiovascular effect, first by their inhibition of calcium influx into myocardial and vascular smooth muscle cells. Calcium channels blockers have diverse effect on the cardiovascular system, means that reduces force of contraction, reduces heart rate. Extracardiac effect: verapamil produces non-specific sympathetic antagonism and has a local anesthetic effect. Routes of administration: calcium channel blockers may be given orally for use in the medical emergency. Verapamil is also available in intravenous form. Therapeutic uses. Number 1. Angina pectoris. Calcium channel blockers are useful in the treatment of both prinzmetal angina and classical exertional angina. Nifedipine appears to be the most effective for prinzmetal angina. Second, nifedipine. It can be combined with beta blockers like propranolol. Nifedipine can be used in premature labor also. Number 3, hypertension. Verapamil, nifedipine, amlodipine, and diltiazem can be used. Nifedipine is also used sublingually in hypertensive crisis. Then arrhythmias. Verapamil is the drug of choice in PSVT, paroxysmal supraventricular tachycardia. Migraine. The calcium channel blockers are also being used for the treatment of migraine. Then peripheral vascular diseases. Nifedipine is useful in the Raynaud's diseases due to its vasodilator effect. Verapamil can be used in the night for the leg cramps. Adverse effect of calcium channel blockers. The calcium channel blockers, perhaps especially when used in combination with beta adrenergic blocking agent, can produce or aggravate the following condition. Number 1, hypotension and bradycardia. Number 2, AV block, congestive heart failure, and asystole. These are the conditions which may get precipitated when calcium channel blockers are taken with beta blockers. Most of the adverse effects are mild. Dizziness and peripheral edema are among the more common adverse effects. Other includes nausea and constipation. Unlike other dihydropyridines, amlodipine does not cause reflex tachycardia. Now about the beta blockers, that is the third category of the drugs used for the management of angina. Beta blockers reduces the frequency and severity of the attacks of exertional angina and are useful in the prevention of angina. Exercise, emotion, and similar situation increases sympathetic activity leading to increased heart rate, force of contraction, and blood pressure, thereby increasing oxygen consumption by the heart. Propranolol. Mechanism of action. Beta blocker prevent angina by blocking all this action due to sympathetic overactivity. They are used for the long-term prophylaxis of the classical angina and may be combined with nitrates. Propranolol may also decreases arterial pressure. Route of administration. Propranolol is usually administered orally for the treatment of angina. Therapeutic use. Propranolol is used prophylactically to decrease the severity and frequency of the anginal attacks. Propranolol can be administered concomitantly with nitroglycerin. In that case, it reduces the amount of the nitroglycerin needed to control angina. Propranolol should not be used for the prinzmetals, or you can say variant angina, which is caused by the coronary vasospasm. Adverse effect ADR of propranolol or beta blockers. Propranolol can worsen CHF and can precipitate bronchospasm in the patient with the bronchial asthma. Bradycardia and hypotension can occur. Renal plasma flow and GFR may be reduced because of the beta blocker. So beta blockers should always be tapped after prolonged use. They are not useful in the variant angina. Now potassium channel opener, that is nicorandil. It is an arteriovenous dilator. Opening of the potassium channel results in hyperpolarization and therefore relaxation of the vascular smooth muscles. Adverse effect includes headache, flushing, dizziness, and hypotension. Uses angina and myocardial infarction. Then dipyridamole, it is a coronary vasodilator, but it diverts the blood from the ischemic zone and is therefore not be beneficial. It inhibits platelet aggregation, for which it is used in the post-MI and the post-stroke patient for the prevention of the coronary and cerebral thrombosis. Trimetazidine, mechanism of action is unknown. By non-hemodynamics, it reduces frequency of the angina and increases exercise tolerance in the patient of angina. Pharmacotherapy of angina. So in acute attack, sublingual nitroglycerin is the drug of choice. If the patient does not subside in 5 minutes, if the pain is not subside within 5 minutes, repeat the dose, maximum up to 3 tablets. After the relief of the pain, the tablet should be discarded. For acute prophylaxis, sublingual nitroglycerin should be given 15 minutes before an exertion, means walking uphill, or before any exertional work, and it can prevent the attack. The prophylactic effect lasts for 30 minutes. In chronic prophylaxis, long-acting nitrates or beta blockers preferred, or calcium channel blockers can be used. All are given orally. If one drug is not effective, a combination of the drug may be used. Then combination of the drugs in angina. Nitrates plus beta blockers. This combination is very effective in exertional angina. Reflex tachycardia because of the nitrate is counteracted by beta blockers. Ventricular dilatation due to beta blocker is opposite by nitrates. Second combination is nifedipine with beta blockers. The anti-anginal effects are additive. Reflex tachycardia due to nifedipine is counteracted by beta blockers. The third combination is nitrate with calcium channel blockers. Nitrate decreases preload while calcium channel blocker reduces afterload, and the combination reduces cardiac workload. The fourth one is calcium channel blocker with beta blocker with nitrates. If the angina is not controlled by two drug combination, three drug can be used. Nitrates reduced preload, calcium channel blockers reduces afterload, while beta blockers decreases heart rate. This combination is useful in severe angina. Unstable angina includes patients with exertional angina developing pain at rest, severe prolonged anginal attack, and angina developing after myocardial infarction. Such patients with unstable angina are at higher risk of developing MI and need rigorous treatment for its prevention. Thank you.